We're going to hold discussions to the end since we're running over this slide.
My friend is our next lecturer. It's very well known to us. His long-standing experience in care, colleagues, and her research. And I'm happy to announce Dr. Sadick from he's clinical professor of dermatology and working at the Cornell Medical College, and he will present his interesting talk on the role of inflammation and immunity in the pathogenesis of human health.
Thank you very much, and I just again like maybe organizers, this has been myself one of the most educational conferences I've attended. So I congratulate everybody. It's been a learning experience each day. We're going to talk about something that I feel is very important in hair loss. It's sort of a new approach that targets the treatment of hair loss in men and women. I have no disclosures at this time, and would like to thank my co-investigators, Dr. Cynthia Magro at Cornell. So the female pattern hair loss, I think, for myself, there are still some questions that need to be answered. I'm still somewhat confused about the classification of hair loss. Most of the women I see in practice have diffuse thinning. There are many women that come to my practice for the first time without any apparent hair loss. They appear to have decreased volume of hair, and I sort of have attributed that to the aging process with loss of volume as we see in other tissues on the skin and deep tissue structures. And then there are a segment of women that have more classic pattern androgenetic hair loss, plus or minus with elevation of androgen. So the reason that I began interested in looking at inflammation in hair loss is because a large majority of my patients, again, complained of symptomology with their hair loss, such as itching or burning. And it was much more than I would have expected. And they were commonly not associated with any changes of seborrheic dermatitis or any other inflammatory skin disease. It was just, again, the symptomology that brought them to my office. We know there are now genetic markers that can be used to isolate the increased propensity to hair loss in both men and women and in certain inflammatory states, such as familial fibrosing and frontal alopecia. But I really have been interested in the pathophysiology of female pattern hair loss. I actually was involved in some of the earlier work with development of alopecia at Cornell, but I never really had a good understanding of working with our investigators on what is the true cause of hair loss in women. So for me, there's really no known underlying pathophysiology for this at this time. And in many women, or most women that we've analyzed, again, there's no biochemical evidence of androgen excess. So, and I think there is somewhat of an unclear influence of estrogen and other estrogen derivatives in this setting. And so for me, again, I sort of have been thinking of a genetic versus senescent component to the majority of women that I see in my practice. I think we understand the role of androgens, such as testosterone, but I think there has been a lot of talk in the literature in the past, but much less understood about the role of inflammation in hair loss. So we've done some other studies on inflammatory states in peripheral vascular disease and acne, which are diseases that have low-grade inflammation and microfibrosis as part of their pathogenesis. Many people feel that many systemic diseases also are associated with low-grade inflammation and subsequent fibrosis. And that's what sort of got me interested in looking at this in women with hair loss. We also know that stress can upregulate TGF-beta or downregulate certain immune cytokines that can be associated with increased progression of cell apoptosis. And these are some of the factors that led us to begin looking at the role of inflammation in hair loss. So this was our first paper that we published looking at the role of inflammation and immunity in the pathogenesis of androgenetic alopecia. Now what we found in a large majority of women biopsied and in some men that up to 60% of women had a very common finding of a lymphocytic folliculitis around the hair bulge area. And we also found in most of those individuals as well trace amounts of granular IgM deposition, again, in that area as well around the hair bulge. So you can see here the more classic lupus band test where, again, you see IgM deposit along the dermal junction. Here in the hair follicle as well, in these positive immunoreactive individuals, significant, again, staining with IgM. So what we saw on a consistent basis was the same pattern. Lymphohistiocytic inflammation around the hair bulge, and again, immunoreactivity in a number of individuals in the same area, or IgM was the common immunoglobulin that was positive. So as we continue to follow these individuals over a longer period of time with sequential biopsies, along with that inflammatory process, we also began to notice some microfibrosis occurring in this area as well. So the inflammation would occur both in those individuals that just had inflammation as well as those individuals that had positive immunoreactivity. But again, in those individuals that had more significant immunoreactivity, there was development of microfibrosis that occurred. So here you see some of the low-grade perifollicular fibrosis that was seen in both groups, again, as I mentioned, were positive in the immunoreactive positive sort of lupus manifest type individuals. And for me, this appeared to be, again, a result of a chronic low-grade inflammatory process targeting the fermentative areas and leading to a subsequent low degree of microfibrosis occurring. So then we went on to look at a study paradigm to see what the role of inflammation, or we could look at inflammation as a potential target for treating these individuals. So in all the patients that come into our unit, in addition to doing blood test screening, we always do a biopsy again with immunofluorescence. And then we sort of segregated these individuals into those that had this inflammatory component, plus those that had positive or negative immunoreactivity. And in those individuals, again, that had significant inflammation and positive immunoreactivity, they were treated with a combination of minoxidil, red light, and a class 1 corticosteroid agent, methadone dipropionate. In those individuals that did not have this immunoreactivity, they were simply treated with minoxidil and red light. So we saw in those studies, and we're now analyzing the data, as that there are more cases, again, those individuals treated with this combination anti-inflammatory approach of minoxidil, red light, and corticosteroid, that there was marked decreased shedding in these individuals, and more cases with analyzable regrowth by cardiogram analysis, and more overall clinical responders in this group that was treated with a combination of, again, anti-inflammatory therapy. Here's individuals, again, treated with a combination from a study of minoxidil 5% plus the corticosteroid with significant improvement. Here's a patient with a negative lupus band test, and there's somewhat less, again, positive, again, response in this setting using just minoxidil plus, again, low-energy red light. So the hypothesis that we've come to is that there appears to be a low-grade chronic inflammatory process in a large number of individuals that have hair loss. And again, this may be a chronic process that leads to subclinical fibrosis and increased dropout of hair cells, probably by increased apoptotic type of mechanism. So our approach in all of our individuals whom we biopsy that has this inflammatory approach, inflammatory finding, is that we utilize both minoxidil and a corticosteroid lotion. So we've looked at other interventions in addition, such as red light, LED, and PRP, because of their anti-inflammatory efficacy as well as having an effect, again, and improving hair cycle characteristics. So again, I think that based on this study that many of our patients can now be looked at as attempting to look at anti-inflammatory therapeutic targets as a source of improving hair loss in women. So the other interventions that we've looked at, again, to try to diminish this inflammatory cycle are low-energy laser therapy. And we're now beginning a large mechanism of action study with Roxanne to talk about this. Though for me, I think that there may be a role of mitochondrial upregulation and diminution of nitric oxide upregulation of cytochrome 450. But we've shown in other studies looking at other inflammatory disease states that we've published, including acne, rosacea, and other inflammatory diseases, that low-energy red light does have a significant anti-inflammatory effect. And again, this may be associated with the downregulation of inflammatory cytokines that may increase cell apoptosis and weaken hair cell fallout. And there have been a number of studies that have been published. This, for me, is the best study looking at this as a monotherapy by itself, improving hair count and hair thickness. And I think we need to know more information about low-energy laser light, but I think that this is an accepted and therapeutic approach in many of our practices. Hopefully our study will give us more insight into the true mechanism of action of low-energy red light. Here's a patient again treated with low-energy light, as you can see here, with significant improvement. And this is just after a few treatment sessions after 3 months with significant improvement in hair loss. Another area, again, that we've been studying and are getting ready to study in hair loss is platelet-rich plasma, or PRP. And we know that there are a number of cytokines and growth factors that can be released, and a number of these factors can, again, stimulate hair follicle growth, but also a number have anti-inflammatory capabilities as well. So here you can see the injection technique. You can use needling, or you can use direct injection of PRP in this setting. And again, there have been 15 studies that have been published, but in my opinion, they're sort of a low evidence in terms of their control and what the true outcomes are. And because of the fact I still didn't feel comfortable again in using this technology without more insight, so we're beginning this multi-center study in the United States, looking at 200 patients, just looking at more sophisticated, again, control evidence-based information to see whether PRP can be helpful in female pattern hair loss, and the subsequent study will be in men as well. But I do believe, in my experience, and we've been using PRP for about 2 years, that PRP will play a role in the therapeutic armamentarium for hair loss in both men and women. There's a patient, again, after 3 treatment sessions, significant upregulation, again, improvement in clinical hair. There's another patient, again, with significant improvement in hair loss just after 3 treatment sessions. And another patient with overall improvement in, again, hair density. But I think this study will give us more quantification as to the exact role of PRP as a sole modality in this setting. So as I said, we're looking for other, again, anti-inflammatory therapeutic targets. So in our practice, we really use a combination if they have this inflammatory phase proven by biopsy of, again, minoxidil, topical corticosteroid derivative, PRP, and red light. And for me, this gives the most anti-inflammatory capability and seems to have clinically given us the best results. But again, we'll need to do a combination study once we finish the low energy light study and the PRP study to see whether this combination truly has evidence-based synergistic efficacy. Some other factors that also have inflammatory activity, we published this paper a couple of years ago looking at injectable cytokines also have both pro-stimulatory and anti-inflammatory efficacy as well. And these, again, agents, when injected into the scalp, do have significant effect on hair growth, but not enough cosmetically to be able to make them as a sole modality, again, in treating hair loss. But again, there are topical cytokine studies that are now being completed and furthering evolution, and I do think that they will play a role in the treatment of hair loss. And then finally, I'd like to talk about other anti-inflammatory approaches. This is a new botanical formulation that's been compounded, again, with minoxidil, and in studies that have been performed that have recently been released, showing again significant improvement using a combination of minoxidil and anti-inflammatory botanicals in improving hair growth in both men and women. And we are doing more hair transplantation. The majority of patients in my practice that are treated are female patients, so we shouldn't forget about that as well. So in summary, I think that inflammation is playing a role in hair loss. These are some of the, again, research projects that are now ongoing in our research group. I'm excited about looking at PRP as a sole modality, looking at, again, our evidence-based information of looking at corticosteroids plus minoxidil, seeing whether it has a appear to be down-regulating that inflammatory cascade. And then we're also looking at low-energy fractional laser systems as well by themselves and with delivery of minoxidil and corticosteroids to see whether they have synergistic efficacy in this setting. So I think we all should be looking at new targets, and for me, one of the major targets, again, anti-inflammatory approaches to hair loss, both in men and women. I think looking at PRP, low-energy light, inflammatory cytokines, perhaps combinations of minoxidil and corticosteroid agents that we use in our practice will give us, again, better therapeutic results in our patient. And most importantly, I think as these studies continue, we need more high-level evidence-based clinical studies to really analyze and assess these therapeutic modalities in a more rational fashion. Thank you very much.
If there's one question, put now for
inflammation in the biopsies and because we know that you can sometimes see inflammation in normal skin, and similarly you can see granular deposition of IgM onto sun-exposed skin. Do you actually have any control biopsies?
There were a control group that was published in the study, right, which did not have the same instance of the inflammatory and reaction changes. And again, we thought about that this could be an epiphenomena from inflammatory disease, seborrheic dermatitis, things of that sort, organisms on the scalp. But again, in all of the patients, there was no evidence of any changes. Were told into control studies looking at this. They were negative, not insignificant.
Just to follow up on that, for the control study for the same people. When we did an arbitrary answer, we definitely got information from non-infected areas in the same individual.
They were not the same individual. They were, again, randomized control versus
Okay, thank you very much. We have to move on. And,